Hi everybody, and welcome to our module on ovarian stromal tumors. There are a lot of different tumors that can occur in the ovaries, but an easy way to keep them straight is to think of three subgroups of tumors that all derive from the different structures normally found in the ovaries. So you're probably aware that the ovaries contain oocytes or eggs, and tumors of these cells lead to germ cell tumors. The ovaries also contain supporting cells like theca and granulosa cells and fibroblasts, and the tumors that derive from these supporting cells are called sex cord stromal tumors, and that's what we'll talk about in this video. And then the ovary also has a surface epithelium that surrounds the ovary, and this leads to adenomas and carcinomas. These are actually the most common type of ovarian tumors, and I talk about these in another video, but in this video we'll focus on the supporting cells. So stromal cell tumors are also called sex cord stromal tumors, and they derive from fibroblasts, theca cells, and granulosa cells, basically all the supporting cells of the ovary. And one thing to be aware of is that these tumors often produce hormones like estradiol, which is an estrogen, and that's easy to remember if you know that they derive from theca and granulosa cells in many cases. These are the cells that normally produce hormones in the ovary. We'll start with the granulosa cell tumors. These are the most common ovarian stromal tumor. They get their name because they are derived from granulosa-type cells. They sometimes also contain theca cells, and then they are called granulosa theca cell tumors. And importantly, these tumors secrete estrogen, and as we'll see in a minute, that's responsible for some of the clinical features, and that's easy to remember if you know that the granulosa cells normally produce estrogens in the ovary. These are usually unilateral tumors, and they may become malignant. They are said to have malignant potential. Most of these tumors occur in adults, about 95%. They occur in women usually in their 50s, and the symptoms, as we'll see in a minute, are from excess estrogen production in the adult. There is a juvenile subtype that occurs before puberty, and this will cause sexual precocity from excess estrogen production. Basically, it will cause the female to undergo puberty at a very early age, sometimes under 8 years of age. So although these are rare in juveniles, what they want you to know for your boards is that if you see a young girl who goes into puberty at 8 years old, you have to understand that there must be some source of estrogen that is abnormal, and one of the potential sources is a granulosa cell tumor. The clinical features are shown in this slide. It often presents as a large adnexal mass. As I said before, it usually occurs in adults, and so adult females will present with estrogen symptoms. One of these is endometrial hyperplasia, which leads to uterine bleeding. So uterine bleeding with an adnexal mass should make you suspect a granulosa cell tumor as a possibility. It often leads to bleeding in postmenopausal women, so women who are postmenopausal don't menstruate any longer. If they start to menstruate, you have to worry about endometrial hyperplasia, and one of the causes of endometrial hyperplasia is granulosa cell tumors. You also have to worry about an endometrial carcinoma in a postmenopausal woman who develops uterine bleeding. And then finally, there may be breast tenderness, and this is from estrogen stimulating the breasts. And then this type of tumor is associated with endometrial carcinoma, and that should make sense to you because it's stimulating the endometrium to grow. It can cause hyperplasia, and it can also cause carcinoma. And when one of these tumors is diagnosed, an endometrial biopsy is often performed to exclude the fact that the granulosa cell tumor may have caused an endometrial cancer. Under the microscope, there is a pathognomonic finding in granulosa cell tumors. It's the presence of what's known as Cal-Exner bodies. These are granulosa cells that surround a space filled with pink material. There are a number of them shown on the slide here. This is one, for example, right here. You can see lots of them in this picture. Cal-Exner bodies, pathognomonic finding in granulosa cell tumors. Next, let's talk about fibromas. These are benign tumors that derive from fibroblasts. They look like a large solid white tumor mass attached to the ovary. This is a picture of one shown on the screen here. They are usually unilateral, and they do not possess any hormone activity, which should make sense to you because they derive from fibroblasts, not from the hormone-producing cells of the ovary. They occur in postmenopausal women, and they usually present as a pelvic or adnexal mass. And there are two classic clinical associations with ovarian fibromas you should know about, and those are ascites and Meg syndrome. Ovarian fibromas are often associated with fluid in the abdomen or in the pleural space in the lungs. So ascites, or fluid in the abdomen, occurs in 40% of cases of ovarian fibroma. Meg syndrome is the triad of ovarian fibroma, ascites, and a pleural effusion, which is also seen in ovarian fibroma. And the thing you want to remember about this is that usually when you see a tumor and fluid in the abdomen or in the pleural space, that usually represents a highly malignant tumor that is spread to the lungs and the abdomen. In this situation, there is a benign tumor in the ovary, and the fluid leak does not represent metastatic disease. That's what's very unusual about these fluid collections developing in the setting of a benign tumor. The etiology of the fluid collections is unclear. It's probably related to capillary leak from tumor factors, although there's lots of debate about what causes this. But importantly, When you remove the tumor, that will resolve the ascites and the pleural effusion. And once again, this is because this is a benign tumor and the ascites and effusion are not from metastatic disease. Next, let's talk about thecomas of the ovary. These tumors usually coexist with fibromas and are called a fibrothecoma. A pure thecoma is a very rare malignancy of the ovary. What you need to know about this type of ovarian tumor is that it can produce estrogens just like granulosa cell tumors, and therefore it can lead to estrogen-related symptoms like endometrial hyperplasia and uterine bleeding. Last ovarian stromal tumor is a Sertoli Leydig cell tumor. These are tumors of the Sertoli and Leydig cells, which are normally found in the testes, so usually this type of tumor occurs in males as a testicular tumor, but rarely it can be found in the ovaries. And these tumors produce androgens because they derive from Sertoli and Leydig cells, which produced androgens. So in a woman, this can lead to androgen-related symptoms like the breast may atrophy, there may be amenorrhea, the woman may become sterile from anovulation, and she may develop hirsutism, and this is a picture of a hirsutized female on the screen here to remind you of that. So these are very rare tumors, but what you want to know for step 1 of your boards is that if you see a case of a female who develops androgen-related symptoms like these shown on the screen here and a pelvic mass, you need to understand that that mass must be producing androgens, and one of the types of mass that does this is a Sertoli Leydig cell tumor, which can rarely occur in the ovaries. And that concludes our video on ovarian stromal tumors.